Welcome to the deep dive. We're here to give you the shortcut to being truly well-informed on complex topics. Today, we're jumping into medical innovation, specifically cancer treatment. It's moving so fast.
It really is. The push is always there to make therapies more effective, sure, but also easier on patients.
Exactly. And our focus today is on immunotherapy for lung cancer. So here's the big question. What if a really effective cancer treatment, one that usually means a long infusion, what if it could be given in, say, just a couple of minutes?
That's the core idea, and it's incredibly exciting, especially when we talk about Pembrolizumab. It's a globally approved immunotherapy, a real cornerstone for treating non-small cell lung cancer, NSCLC. It's made a huge difference.
Absolutely. And the reason we're talking about this now is a brand new phase 3 clinical trial. It's the 3475 AD77 study, just published March 27th, 2025. Our mission today: to unpack what it found comparing the under-the-skin subcutaneous version versus the standard IV infusion for metastatic NSCLC. You'll get the key takeaways right here. Okay, let's start with the basics. Why even explore this? Why would doctors, or patients for that matter, prefer a subcutaneous injection, SC, over an intravenous IV infusion?
Well, there are some really compelling reasons, especially when you think about the patient experience. The study background mentions things like higher patient satisfaction
Okay.
and a lower emotional burden, less anxiety, less stress tied to treatment time.
That makes sense. Less time hooked up to an IV pole.
Exactly.
Yeah.
And often just a strong patient preference for the quicker subcutaneous route. Imagine dealing with metastatic cancer, getting your treatment quickly and going home. That's a big deal.
It really is. So this isn't just about making things slightly more convenient. It sounds like it could genuinely transform the whole treatment experience for someone with MNSCLC, metastatic disease.
Precisely. And it's not only the patient side. Think about the clinics, the healthcare providers.
Mm.
Subcutaneous delivery can really streamline things. The study suggests improvements in administration workflows.
Meaning faster appointments.
Yes, shorter clinic times overall, less provider time needed per patient compared to that typical 30-minute IV infusion.
Right, which ties up chairs, staff.
Exactly. Freeing up those resources could mean treating more patients, maybe cutting down wait times. It has knock-on effects.
Okay, so let's get into the science a bit. How does this subcutaneous version, MK3475A, actually work? It's not just the standard pembrolizumab, right?
No, it's a specific formulation. It combines pembrolizumab with something called hyaluronidase alpha. MK5180 is its code name.
Hyaluronidase alpha. What does that do?
Think of it as a permeation enhancer. The tissue under your skin has this substance, hyaluronin, kind of holding things together. This enzyme, the hyaluronidase alpha, temporarily breaks down that hyaluronin right at the injection spot.
So it loosens things up locally.
Exactly. It makes the tissue more permeable for a short time, allowing that larger dose of pembrolizumab to disperse and be absorbed effectively. That's what makes the subcutaneous delivery feasible for both the every 3-week and, in this study, the every 6-week dosing.
That's clever. So how did they land on the right dose for the subcutaneous version, the 790 milligrams?
Good question. It wasn't random.
Yeah.
The source mentions a prior phase I study, 30475 AC18. The results from that study helped them pinpoint this specific dose, 790 milligrams at 165 millijoule air, given every 6 weeks, as the one to take into this larger phase 3 trial. It was data-driven.
Okay, so now we get to the main event, the 3475 AD77 trial itself. Let's paint a picture. This is a pretty significant study.
Oh, absolutely. A global effort. It was an open-label randomized phase 3 trial.
Open label meaning both patients and doctors knew which treatment was being given.
Correct. And phase 3 means it's designed for those definitive answers on efficacy and safety. It involves 61 sites across the world.
Wow. And who took part? What were the patient characteristics?
They enrolled 377 people. Key things: newly diagnosed stage 4 NSCLC, either squamous or non-squamous type. And importantly, they hadn't had prior treatment for their metastatic disease.
Okay.
Also crucial, they didn't have those specific targetable mutations like EGFR, ALK, or ROS1. Those patients typically get different therapies first.
Right, so this was focused on the broader population, often treated with immunotherapy plus chemotherapy upfront.
Exactly, and they were randomized 2-to-1. So twice as many patients got the subcutaneous version compared to the intravenous one.
Okay, let's break down the two arms very clearly. The subcutaneous arm first.
Right, those 251 participants, they got Pembrolizumab S.C, that 790 milligram dose every 6 weeks, plus standard platinum doublet chemotherapy, and that median injection time, just 2 minutes.
2 minutes compared to...
Compared to the intravenous arm, that was 126 participants. They got Pembrolizumab IV 400 milligrams every 6 weeks, also with the chemo. And that infusion typically takes about 30 minutes.
Big difference. So what were they primarily measuring? What were the main goals, the endpoints?
They had dual primary endpoints, both focused on pharmacokinetics, basically, how the drug behaves in the body. They looked at the total drug exposure over the first 6-week cycle, called the AUC, or area under the curve.
Okay, the overall amount.
Yes. And the trough concentration, cran trough, which is the lowest level of the drug right before the next dose is due.
Making sure enough is still there.
Precisely. The goal was to show non-inferiority. Essentially, proving the subcutaneous version wasn't worse than the IV version on these measures, within a preset statistical margin of 0.8 for the geometric mean ratios.
Okay, makes sense. So the crucial question, did it work? Did the subcutaneous version deliver comparable drug levels? Because that underpins everything else.
Absolutely.
Yeah.
And the answer, based on this study, is yes. It met both primary pharmacokinetic endpoints. Connecting this to the bigger picture, they demonstrated non-inferiority for both that cycle 1 AUC and the steady-state trough concentration.
So the drug got in and stayed around effectively?
Yes. The geometric mean ratio, the GMR for the AUC, was 1.14, and for the trough level, it was 1.67, both well above that 0.8 non-inferiority margin, with p-values less than 0.0001, indicating statistical significance.
Interesting that those ratios are actually above 1.
That's right. There were some nuances. While non-inferiority was met, the subcutaneous route actually resulted in relatively higher overall exposure and trough levels at steady state. Peak concentrations, Cmax, were a bit lower compared to IV, but those higher overall exposures were still well within the known safe range for Pembrolizumab. So no safety red flags there.
That's really key. Okay, pharmacokinetics look good, but what about actually fighting the cancer? Did the subcutaneous form work just as well? Efficacy.
That's the bottom line for patients, isn't it?
Yeah.
And the efficacy results were very comparable between the arms. The objective response rate, ORR, that's tumor shrinkage, was 45.4% in the subcutaneous group versus 42.1% in the IV group. Very similar.
Okay.
Median progression-free survival, PFS, how long patients lived without the cancer progressing, also very close. 8.1 months for SC versus 7.8 months for IV.
Almost identical.
And the duration of response, DOR, how long the treatment kept working for those who responded. Again, similar. 9.1 months SC versus 8.0 months IV.
So across the board, it looks like it performs just as well clinically.
Based on these measures, yes. They did note that overall survival data is still immature. The study hasn't run long enough yet, with a median follow-up of about 9.6 months. But the early signs on efficacy are certainly aligned.
Got it. What about the body's reaction to the drug? Immunogenicity. Did giving it under the skin cause more patients to develop anti-drug antibodies? ADA.
That's always a critical question with biological drugs, especially new formulations. And the news here was very positive. The rates of treatment-emergent ADAs were really low in both groups. Only 1.4% in the subcutaneous arm developed them, and just 0.9% in the intravenous arm.
Wow, that is low.
It is. And it's right in line with what we've seen historically with intravenous Pembrolizumab, which is around 1.8%. Crucially, even in those few patients who did develop ADAs, there was no sign that it affected how well the drug worked or its safety.
That's fantastic, because sometimes changing the delivery route can increase immunogenicity, right?
It can, yes. And that's been observed with subcutaneous versions of some other immunotherapies, like atezolizumab and nivolumab, which saw somewhat higher ADA rates compared to their IV forms. So this low rate for SC pembrolizumab is a really encouraging finding.
Okay, so drug levels are comparable, efficacy looks similar, immunogenicity is low. What about safety and the patient experience overall? Any new concerns with the injection?
Safety is paramount, of course. The study showed the overall safety profile was consistent between the subcutaneous and intravenous groups, rates of treatment-related side effects, serious side effects, and patients stopping treatment due to side effects all very similar. No new safety alarms went off just because of the administration route.
That's reassuring. What about reactions right at the injection site? You mentioned that's a common concern.
Yes, and they look closely at that. Injection site reactions in the subcutaneous arm were actually quite infrequent, reported in only 2.4% of patients, so just 6 people out of 251. And when they did happen, they were mild grade 1 and not serious.
And nobody stopped treatment because of them.
That's right. No discontinuations due to injection site reactions, which is great news for tolerability.
And we have to come back to that practical advantage. The median time for the injection was just 2 minutes.
2 minutes. It's worth repeating because it's such a stark contrast to the 30 minutes for the IV infusion.
That's a massive time saving for the patient, for the clinic.
Absolutely. And importantly, they also looked at quality of life measures. Things like global health status, physical functioning, role functioning, how well people could do their usual activities. These were also similar between the two arms.
So patients get their treatment much faster without any apparent downside in terms of safety, efficacy, or overall quality of life.
That's what these findings strongly suggest, yes. Less time in the clinic, same benefit.
Okay, so let's wrap this up. What's the big takeaway here for you, our listener? This 3475 AD77 study seems pretty conclusive. Subcutaneous pembrolizumab looks like it holds its own against the IV version.
It really does. It demonstrated non-inferiority in those key pharmacokinetic measures, drug exposure, trough levels, and it showed very similar efficacy results and a consistent safety profile in this group of patients with metastatic non-small cell lung cancer.
So what does this mean looking forward? What are the broader implications?
Well, this raises a really important question about the future. These findings provide strong support for subcutaneous pembrolizumab being a viable option, potentially for all the approved indications where IV pembrolizumab is currently used, not just lung cancer.
That would be huge.
It could really change things. Think about the healthcare system impact, potentially streamlining how treatment centers operate, freeing up those infusion chairs and nursing time we talked about. It could lead to more efficient use of healthcare resources.
It's about making effective treatment more manageable, both for the system and, crucially, for the patient. So here's a final thought to leave you with. Imagine a future where spending hours in a clinic for essential cancer therapy is significantly reduced for many patients. How could this shift, driven by an innovation like a simple change in administration route from IV to subcutaneous, reshape patient lives? And how might it ripple outwards, potentially improving access and making these life-saving treatments more manageable on a global scale? It's amazing how these scientific advances can have such profound human impacts.